Hello, everybody, and welcome to the PT on Ice Daily Show. My name is Christina Prevett. I am one of our lead faculty within our Modern Management of the Older Adult Division, our geriatric division. And today I wanted to talk to you about constipation in older adults. When I was a new clinician, and I still kind of think this now, is that it was amazing how many of my conversations with my older adults, especially when I had the gym and we were kind of talking a little bit more on a regular basis, where pooping would come up or like the lack of pooping. And as I got into pelvic health, I obviously learned a lot more around constipation management. But we know that older adults have big problems with constipation. And I read a stat in a paper the other day that said that 80% of older adults in nursing home would be considered constipated, and 50% of them would hit the diagnostic criteria for fecal impaction. And some of the downstream negative consequences of things like fecal impaction are like perforated bowels and infections. And it can literally be life threatening. And as a rehab clinician who it is very much in my scope of practice to help with constipation management, I really think that this is a big miss where we as the rehab team can be helping with this problem. And so I'm going to kind of do this section or this series on constipation in two parts. The first one today is I'm going to talk about the 5 main reasons why constipation increases with age. And then the next time I'm on in a couple of weeks, we're going to talk about what to do about it. So, when we are thinking about the 5 main reasons why older adults have more issues or frequency of constipation goes up, they are age-related changes to the GI tract, pelvic floor dysfunction, which increases with age, nutritional considerations, which with age-related components and just the way that nutrition can deviate, physical inactivity, and oh my goodness, medications. So we're going to talk about it. So first and foremost, there is a reason why so many dysfunctions increase with age, right? It's because we lose a lot of reserve in all of our organ systems as a consequence of getting older. And so age-related changes in the GI tract is that we have a decrease in gut motility. Things get through the intestines slower, and because of that slower transit time, it can make individuals more likely to be constipated. And so it is an issue where we have underlying changes to our gut that make it more difficult for individuals to pass stool. Put this in combination with other factors, and this can kind of be the perfect storm. So the second thing that we see is that pelvic floor dysfunction can be a reason for constipation. The 2 main considerations, one is posterior wall pelvic organ prolapse. So prolapse is an increase in range of motion of one or more of the vaginal walls towards the vaginal opening. Stage of prolapse is relative to the hymen, and the risk for higher stages of prolapse increases with age. And so as we get older, we spend more time in a low estrogen state. Our vaginal walls have an increase in range of motion. And so if my posterior wall is coming down towards the vaginal opening, what that can do is it can create a pocket of space for stool to essentially get stuck. And so what it can do is it can make it really hard for people to evacuate stool, or it can make people feel like even if they do poop, that there is an incomplete emptying. And so what some people have to do is they have to stick their finger into their vagina and pop some support into that posterior wall to unkink that angle to allow poop to pass through. And so if there is this kind of pocketing of the vaginal wall and it's creating issues, then we're also getting the secondary piece, which is high amounts of straining to poop, like face is going red, you're trying to bear down to evacuate, and it just isn't happening. So with that, one, it can create a lot more pelvic floor dysfunction. This can actually make some of our symptoms of prolapse worse. And it's a risk factor for pelvic floor dysfunction, but it can be the pelvic floor dysfunction itself that is creating issues with stool. The second piece of this is that if there's an underlying weakness issue, and this is not just the pelvic floor, but also the core canister, then even that amount of pressure coming down may be insufficient to clear stool, especially when it's hard or lumpy. And so, what that can do is, again, it creates this spinning wheel where individuals are having pelvic floor dysfunction. And so, they're creating this issue with constipation. And then, with that constipation, it's causing more pelvic floor dysfunction exacerbation. And now we're kind of going into this loop where individuals are having a high burden of bowel and bladder symptoms that it's very hard to get ahead of. And then they are going on more and more medications for these issues. So we have these age related changes and we have pelvic floor dysfunction. And then we have other things that are kind of these modifiable lifestyle factors. So we have things like nutritional considerations. So individuals who are dehydrated and not getting enough fiber in their diet are at risk for constipation. From an age related change perspective, our drive for thirst, our thirst drive decreases with age. So, for example, if you were having this feeling of thirstiness, because in the morning, because it's the first thing in the morning, you woke up, you're thirsty, you want some water. That drive may not be as strong in your older adults. Like they don't have that connection as strongly that, oh, I should probably drink some water. And so it's very easy for our older adults to one, get dehydrated, which is a big risk factor when you have hard or lumpy stool. And when we are having issues with pooping and peeing, we can change our nutritional strategies to try and make this better. Like, for example, my clients oftentimes with pelvic floor issues, my older adults, they won't drink any water before they go out because they're afraid they're going to have an accident while they have to be out in town or whatever. And so you could end up in, sorry, this malnutrition loop where they are having difficulties because they're not drinking enough water. It's creating hard and lumpy stool. But when they do drink more water, they're feeling more pelvic floor dysfunction. And so we have to kind of break down where that is going. Like I'll have a lot of clients who will go from coffee to wine, which can sometimes be difficult, like when you are having or struggling with constipation. So I hope that you can see too is like while I have these in buckets of like age related changes, pelvic floor dysfunction, nutrition, they also are very interconnected. And we're going to keep going with this interconnectedness as we go into our fourth consideration, which is physical inactivity. So if your body is weak, your pelvic floor is weak too. If you are sitting on your butt for the majority of the day, it is very hard for you to start moving your bowels, right? Having physical activity, having blood flow to the rectum, to the lower GI tract is a way to help stimulate that urge to defecate. And so if you are more sedentary, not only are we in a more pro-inflammatory state, which can influence our bowels, but it also is going to make it more difficult for us to have the urge to go to the bathroom. And so when we think about our older adults in nursing homes and long-term care, some of our stats on their level of activity is kind of scary. Like there are some stats where it's like 21 to 22 hours of the day is spent lying down or sitting and completely sedentary as we get into higher levels of institutionalization. And now there's a lot that goes into that, obviously, right? Because they're in higher levels of institutionalization because they need more care. But part of that is administrative, and a part of that is just that the way that the system is set up, that the environment is not conducive to having or encouraging more movement in those patient populations because they need more help. And what that can do is it can create this problem where because they are not moving enough, they are having a very hard time sensing an urge that they need to go to the bathroom. And so you can kind of see how a lot of these things go back to each other. Urinary incontinence and constipation is considered a syndrome where there are lots of constellations of signs and symptoms that are creating issues with these kinds of issues within the bowel. And so they really are interconnected. So we have age-related changes, pelvic floor dysfunction, nutritional considerations, physical inactivity, and then a final one that oftentimes is not in the modifiable camp is medications. There are so many drugs that our older adults are on where one of the side effects is constipation. Big ones, opioids, right? Everybody knows about that morphine-induced constipation, opioid-induced constipation. And a lot of our older adults are on some sort of pain medication. And also our medications for urgency. I don't know why there is balloons going on in the background. That is an interesting thing on Instagram. So the second one is that our anticholinergics that we oftentimes use for bowel symptoms like overactive bladder, because you're having less urine flow or less water coming through the renal system, one of the big side effects of those drugs is constipation. And so, and antacids is another one. We have a lot of older adults with GERD. And so we are seeing that a lot of these big classifications of drugs that our older adults are on all the time, their consequence is constipation. And when we have those drugs, now we're having separate problems that are coming up that are making it difficult for individuals to engage and have a good quality of life. Because I don't know if you have ever been constipated, but it is miserable. Like you're feeling very bloated, you have abdominal pain, you can have back pain and cramping, you just feel like this kind of malaise. And if you're also straining a lot, then it could make you more sensitized around your pelvis. Now you're feeling pelvic heaviness and discomfort. You can be having hemorrhoids and things like that that happen as a consequence of constipation. And now we also have the downstream risk factors of fecal impaction, where that stat that 50% of our individuals in nursing home have constipation so severe that it is fitting the criteria for fecal impaction is massive. And as rehabilitation providers, we do have a role in constipation management. Are we going to be able to change age-related things? No. Are we going to be able to change their medications? Likely not. But their pelvic floor dysfunction, counseling on nutrition, and the physical activity piece, and then proper bowel and bladder habits, which we're going to talk about in part 2 of this little 2-part series that I'm going to do on constipation, is within our scope in rehab. And if we could prevent even one downstream consequence of fecal impaction where we prevent a perforated bowel by telling people how to pee and poop properly, my goodness, it could be such a huge benefit for our older adults and reduces burden on our healthcare system and improves our older adults' quality of life. And we just have such a huge role to play. So I hope you all found that helpful. I always say, and you guys are probably like, Christina, you're such a broken record, is that if you were in geriatric practice, like you need to be screening for the pelvic floor stuff. You need to be screening bowel and bladder because it is such a big issue with our older adults, and it is definitely within our scope of practice. If you are looking for more information around some of our thoughts around pelvic floor dysfunction, we actually cover pelvic floor dysfunction this week. So we're doing week 5 of our level 2. So if you've taken level 1, you want to get into level 2, which is like our special populations. We are starting our next cohort up in January. Make sure you jump into that cohort. We only have one more live course coming up for that you can jump into. For MMOA in 2024, it is with me in Loveland, Ohio, which is near Cincinnati, December 7th and 8th. Then we are getting back on the road January 18th and 19th in 2025 in Hendersonville, Tennessee, just outside of Nashville. And then January 25th, 26th, I'm going to be in Athol, Idaho. So if you guys are looking to get into our live courses in 2025, those are our first 2. Otherwise, I hope you all have a wonderful week. I love nerding out about geriatric pelvic health. I think it's such an underappreciated and underserved area of our practice, and we have a huge role to play in the quality of life of our clients. And if you are in higher levels of institutionalization, they'd oftentimes don't have access to specific specialized pelvic floor physical therapists. So guess what? You're it. So if you guys have any other questions, let me know. Otherwise, I will see you for part 2 of this series when we talk about what the heck we are going to do about it. And hope you all have a wonderful